Hi, everybody. Welcome back to the Get Healthy Tampa Bay podcast. I'm your host, Dr. Kerry Reller, and today we have Dr. Sheila Perez-Colon. Why don't you introduce yourself and tell us who you are and what you do?
Thank you so much. So yes, I'm Dr. Sheila Perez-Colón. I am a board-certified pediatric endocrinologist. I currently practice in Puerto Rico. My practice is called Elite Endocrine MD. I did part of my medical school in Guadalajara, in Mexico. Then I completed it in New York. My residency, my fellowship, I completed in New York, and then I worked there for 5 years. While there, I was the director of the diabetic clinic, and I saw different kind of pathologies within endocrinology. After that, I went to LA, and then I finished in Miami for 3 years. But now I'm back to the island because there's such a need of pediatric endocrinologists in my island, Puerto Rico.
Absolutely. How did you choose pediatric endocrinology? That's pretty specific. So how did that come about?
Well, I always love kids, right? Children, their imagination is so big, right? There's so many possibilities, but at the same time, they're so vulnerable when they are sick. So I wanted to be able to help them. For endocrinologists, and the endocrine system is very complex, but for me, it's very exciting because it's like a puzzle, trying to put together the puzzle to try to help the patient. If we have an excess of the hormone, there's some conditions that can develop, and I could participate and work with the patient to bring it down to normal and to balance. In the opposite, if there's a deficiency of the hormone, again, it could lead to many conditions. So I could help this patient to bring it back to balance. So for me, that was very exciting.
Awesome. I think definitely endocrine system is one of the more complicated systems. So being able to translate that for the patient and work with them is super important. You mentioned diabetes. That's probably the most common endocrine disorder. And today we were going to focus on type 1 diabetes. So can you walk through the difference between type 1 and type 2 diabetes for us?
Sure. So type 1 diabetes, first of all, both type 1 diabetes and type 2 could happen in children. Many years ago, we thought type 2 is only for adults. Unfortunately, that is not the case nowadays. But for type 1 diabetes, it is caused by an autoimmune condition. This means there's some proteins running around in the body that at some point could bind to the pancreas, which is the organ which produces insulin to keep the blood sugar normal. So if that pancreas is not working properly, there's not enough production of insulin. And this will lead to high glucose levels or sugar levels in the blood. But this is important to know that this is not caused by maybe some juices or candies that the patient may have eaten in the past. There's some susceptibility for the patient to develop. Why does it happen? Nowadays, we still don't know, certainly. However, there's some association or link between some things and factors. For example, like you could have, or the child or adolescent could have a virus or a bacteria, an infection many years ago, and now they could present it. Just as a review, we know if there's an infection, our body tries to produce and to keep us normal, right? To fight that infection. And that's where the antibodies could be produced and could lead to diabetes type 1. This could happen from maybe past 6 months of age up to even an adult, we could develop type 1 diabetes. And the management will be different. For type 2 diabetes, actually, it's not autoimmune. This is more kind of genetic, right? Like if there's a family history, we have an increased risk of having type 2 diabetes. This is due to an increase in weight, due to insulin resistance. And the pathology there, it's like, again, our body is working so hard to keep the sugar within normal level that at some point it kind of give up. And the risk factor, the main one is family history and obesity. So yeah, this is the difference between type 1 diabetes and type 2 diabetes.
Other than the treatments, obviously. The type 1, so it can be genetic as well, right?
So for type 1, we do say there's some genetic susceptibility. So yes, there's some maybe HLA like haplotype and some other things that we need to have. So if we have two children with, for example, one has the characteristic or the susceptibility and the other doesn't have it, the one that doesn't have it will not develop. So it's not on every patient who has, we think that could develop type 1 diabetes. Will it happen to everyone? No. You need to have some susceptibility for that to happen.
Okay. So how does it typically present? What symptoms might a patient have?
Yeah, so this is very important for everyone who's listening because it could be very vague symptoms, but it's something that we should be aware of. So the patient or the child, adolescent, and even adults could present with increasing urination. Suddenly they were going, just to say, maybe 3-4 times to urinate during the day, and they are going like 10 times. Or they need to wake up now at night to urinate, and this is new for them. Or maybe the child was already toilet trained and they're 8, 9, 10, and suddenly they're having some accident in the bed. So those are some symptoms, sign of diabetes. Why does this happen? Because our body and our kidney just can handle certain level of glucose or sugar in your blood. When it is higher than that, it will go through the kidney. We will urinate that glucose or that sugar, and water goes after that. So there will be an increase in urination. So in medicine, we call it polyuria, which is increasing urination. That's one. The other one is called polyphagia. That means that the child or the adolescent is having an increase in hunger, where like you just ate like 2 hours after they're eating again. And it's important to know it's a change in the pattern. It's not a kid that has always been eating a lot or has an increase in the appetite. It's something that suddenly changed, maybe 2 weeks, 1 month, 2 weeks, 2 months prior, they were not eating like that. They were not always hungry. So increasing hunger is the second one. The third one will be like they could be tired all the time. Suddenly they're like always tired. They want to sleep all the time. That is a red flag for that. Weight loss, unintentional weight loss. They're like suddenly losing weight and we're like, oh, this is so good. They're losing weight, but they're eating maybe more and they're not doing exercise and they're losing weight. And then always thirsty, like I mentioned before, because they are urinating a lot. We get dehydrated, and that's why our third mechanism increase, and we're always thirsty. So these are some of the signs or symptoms that we should be looking for, because if our kid, adolescent, or even adult present with any of those, this should trigger a visit or let us know. Let me check with the doctor to make sure it's not that the child is having diabetes or high blood glucose.
So do the primary doctors typically catch this first, or I mean, I know that I'm kind of leading you because I think sometimes it is a presentation into the emergency room. So what do you normally see?
Yes, there's some parents that will be worried about those and they will go to the pediatrician. So that will be kind of the first visit. They send the blood work and we can talk about how we diagnose it. And that's where we can catch diabetes. But unfortunately, many of the new patients, we call it new onset diabetes. They didn't have diabetes before. They present already to the emergency room because they're having some belly pain. They're having some vomiting, some dehydration, but they didn't know why. And then when we check, they have diabetes, and actually they present with a complication of diabetes to the emergency room, which is known as diabetes ketoacidosis or DK.
So you mentioned diagnosis. Why don't we talk about that? How do you diagnose type 1 diabetes?
Sure. So we have different ways of diagnosing type 1 diabetes. One of them is known as the hemoglobin A1C. This level gives us an idea approximately of the past 3 months. How is the blood sugar, the mean glucose level past 3 months? We use it to diagnose even pre-diabetes or diabetes. So the level should be less than 5.6. When that level is between 5.7 to 6.4, it's considered pre-diabetes. But when it is 6.5 and above, it's considered diabetes. And for this, it's not just one single value. This is if the patient is having the symptoms that I mentioned before. Otherwise, we confirm that. But that's one of the ways that we use to diagnose. The second one is a fasting glucose level. So when we are fasting, the patient hasn't eaten at least 8 hours overnight. They go to the laboratory in the morning. We check that glucose level. If that level is 126 or above, this suggests that the patient may have diabetes, right? Again, if it is confirmed or having some symptoms, but 126 or above is another way to diagnose this. The third one is like random sugar, meaning we then like an hour, 2 hours after we go to the laboratory, we check our level and it is above 200. That's the third way we could diagnose. And number 4, it's called an oral glucose tolerant test or an OGTT. This is the test that maybe many moms will recognize that test. We go and drink a sugary drink. It's a very loaded drink with a lot of sugar. And then we check the glucose level. 2 hours, it is above 200 as well. Then we diagnose the diabetes. Something important to differentiate, many persons think we could diagnose diabetes with the urine analysis. right? Is when we urinate. And that could give us an idea, right? The sugar, the glucose may be increased in the urine, or we may have some ketones there, but that's not a way to diagnose it. So for diagnosis, 4 of them: A1C, fasting glucose level, random glucose level, or oral glucose tolerance test.
Awesome. Yeah, those are really good tests that help diagnose it. They're similar ones that we use for diagnosing type 2. So we talked about how it presented. You mentioned the complication of diabetic ketoacidosis, but are there any other kind of complications that occur from having type 1 diabetes?
Yes, there's complication of poor control type 1 diabetes. That means that your sugar has been always running on the higher side, or that A1C level is always on the higher side. In pediatric, we aim to, I mentioned the diagnosis is an hemoglobin A1C of 6.5 and above, but within pediatric, once we make the diagnosis, we wanted to have it close to 7, and the guideline will vary 7.5 per age, but that's where we wanted to. Why? Because studies have shown that if that hemoglobin A1C is above like 9, 10, 11, 12, the risk for complications increase. And those are, for example, like eye conditions or eye disease, which we call retinopathy, right? It could affect our kidneys. So this is called nephropathy, and our kidneys start to work properly, right? And we may depend on dialysis at some point if it is not well controlled. Another one is called neuropathy, which means diseases or conditions of the nerve. So these are the most complications that we see with diabetes, type 1 and type 2, actually. With type 2 diabetes, we may see it a little sooner. And why? Because usually silent. We may not notice the sign or symptoms with type 2 diabetes. Type 1 is more acute, so we will go and get checked. But for type 2, many patients may live with type 2 diabetes and they may not know it. But actually, the complications are the same. What makes it a little different is this one that I mentioned called DKA, diabetes ketoacidosis, which means like your sugar was so high that you were dehydrated and you needed to now not only receive insulin, we give it like through subcutaneous, like we need IV insulin. And that's why they need to be admitted to the hospital. So DKA is mainly a complication of type 1. However, to make it a little more fun, type 2 diabetic patients could present with DKA, but it's not the typical.
Right. You mentioned insulin. So let's talk about the treatment for type 1 diabetes. Can you go into that?
Sure. And I wanted to mention something a little about the diagnosis, how to differentiate that I forgot to mention. Now that I mentioned the 4 things or studies that we could use to diagnose diabetes, that cannot differentiate between type 1 and type 2. And you mentioned that, right? We only know that that's diabetes. But if we want to know if it's type 1 or type 2, we order further testing, and it's blood test called the pancreatic antibodies. Then we want to know about those proteins that are running around. Are they present or not? If they are present, most likely, and this patient will be diagnosed with type 1 diabetes versus the one that doesn't have it, it's likely this patient have type 2 diabetes. Type 1 diabetes, typically the patient are more thinner. They don't have obesity, the condition of obesity. With type 2 diabetes, these patients have obesity or overweight. And then in terms of management for type 1 diabetes, there's lack of insulin, so we need to give insulin. The treatment is for a lifetime. The patient will always require insulin. But good news is like nowadays, thank you to the technology, we have so many methods to administer the insulin. So in the past, there was just syringes and a vial, right? And we will get the insulin and give it. We still can use that and we can get good control, but we have options. For example, one of them is called the insulin pen. It's just like a typical like pen, and it has insulin inside. So we can just dial the units that we need for the insulin and we could administer. Another way that we can do that is via the insulin pumps. The insulin pump are these kind of devices or machines that we can put the insulin inside the machine, and this machine will be giving some insulin without us needing to be injecting all the time. For that, you go to the doctor, we order, see if you're a candidate for that. We put some setting in the machine, so the machine will be giving you the insulin that you personally need. There's some rules for that, to cover for food and to bring your sugar down, which is called correction factor. Even though 2 persons could have the same insulin pump, The settings will be different because it will be according to the weight and all that. But with that one, you don't need to change it for days. So patients don't need injections. Some days they will be without any injection, just pressing the pump. Plus, now, when we are diagnosed with type 1 diabetes or even type 2, we need to be checking our glucoses, right? It's not like magic that we're just randomly give a number of units of insulin. It doesn't work like that. So for that, we need to check our sugar levels. And we have what we call a glucometer, which is a meter to check the sugar level. And it's by pricking your finger. This is the one that all of us know because it's one that has been out for years. And this is good. But now we have something called a continuous glucose monitoring. What is that? There's different brands, but technically it's a very small device that you can put. It depends on the age, but you can put it on your abdomen, you can put it on your arm and in other places in your thigh, and it will give us your glucose levels or a reflection of your glucose level. One of them is like every 5 minutes, which imagine how amazing is that, right? Every 5 minutes, you know your sugar. After you eat, you know how it's changing. Plus, it gives you an idea on how it will be changing within the next hour. So you're already prepared. And the magic of this is for kids in pediatric. With these devices, you have the option for the parents to see it. So the kid is, I don't know, in a soccer game, the kid is in the school, but the parents can have, or the guardians could have peace of mind because they will see it on their cell phone constantly. How is the blood sugar? So it's amazing.
So you were mentioning activity, and you also said the insulin is calculated based upon weight, right? So that's how you would know that. I'm going to ask a question about nutrition in a minute, but the activity level, can the kids go out and play and be a normal kid, or how does that factor into their diagnosis?
I'm glad you asked that because the first thing I mentioned to the parent, to the kid who is diagnosed with diabetes is that your life, your activities shouldn't change. Not because you have diabetes, you should be limiting your life, right? Your lifestyle. You can continue in your soccer team. You can continue dancing. The only thing, it may take maybe a little extra 5 minutes because we need to check your blood sugar. And if it's high, we need to react to that. If it is low, we need to react. But there is no limitation. Diabetes should not limit the patient. That's very important.
I definitely wanted to make sure we said that for sure.
Yes.
So how would their diet be any different than another child's, or can they eat whatever they want? How does that work?
Yeah, so definitely we need to have a modification in their eating pattern, no doubt. We start with sending them to the nutritionist or registered dietitian and to make sure they have close follow-up with them. But ideally, we need to decrease the carbohydrate intake, for example, meaning they should be eating less amount of sugar. We need to be monitoring what they're eating. It doesn't mean that they cannot eat carbohydrate at all. It's like, no, they cannot go to a birthday party and eat cake, nothing like that. Everything in moderation. But yes, we need to be paying close attention on the balance on the plate. Like other patients, right? I say this to all my patients. We need to take a look at your plate. You have like half of it should be like fruit and vegetable, then the other half divided by another half, 1/4. Monitor the amount of carbohydrate, and then the other your proteins. So the answer is yes, we need to be paying more attention, make sure we're not eating a lot of sugar. But again, they're kids. So as long as we're monitoring what they're eating, they could have special occasion, and we just need to cover for that.
So I guess they can eat basically a balanced meal. They're learning about nutrition at a younger age. And I think that is super helpful and important to be able to do that and live life as a kid. But as far as their management, you mentioned parents being able to look into the app. Does that help keep their blood sugar in better control on a typical basis then when they're more involved?
Yes, definitely. Studies have shown, I see it daily in my clinic, but studies have also validated that yes, once the parents are involved and with us have an idea every 5 minutes of your blood sugar, for example, yes, you will react more. In the past, if the parents are not involved, for example, and they lead it to the kid, we tend to see higher blood sugar and less action maybe. Sometimes they forget to give the injection, but with the guardians around, having some accountability, definitely we see those hemoglobin A1C more closer or close to where they should be.
So you also mentioned the carbohydrate. Can you explain so everybody understands why they need to have reduced carbohydrate?
So carbohydrate, and this is in simple ways how I explain it to my pediatric patients, right? It's like carbohydrate, even though you don't see sugar, when you eat it, when you put it in your mouth, it gets converted into sugar. So we know that it will lead to an increase in blood sugar. Our aim to treat or manage diabetes is to prevent those spike and increase in blood sugar. So that's why we need to decrease it. Carbohydrate, for example, it could be like bread, your pasta, your rice, your potato. All those are examples of carbohydrates. So we want to eat it in moderation. But that's why, even though they doesn't look like sugar, it does get converted into sugar in your body. And again, so that will lead to an increase in blood sugar. And that's why we want to prevent, not a big spike in the blood sugar.
Are there any, I guess, other later complications from having type 1? I mean, we talked about some of those things, but what do you see the most of, I guess?
So I guess within our population in pediatric, we don't see as much as an adult because there's so many years. But let me tell you, patients who are not controlled, I remember in New York, like I did have patients who were like 17 years old and already on dialysis. So we do see it. Unfortunately, we do see it. If we don't take good control of our blood sugar, it will lead to that if we are always on the higher side. But most of them, since they will be having the condition for lifelong, you will see it as an adult. We need to take care as of now because we do see it in pediatric. If you don't take care of your blood sugar, we can see it still within your pediatric age, the complications, yes.
So as far as treatment, is insulin the only thing that they need to take as a kid?
For type 1 diabetes, yes. Right? Okay. There's a decrease. So I always explain, let's go back to the basic. If the problem is we're not producing insulin, and insulin, we call it, is like the key, right, of the cell to let the glucose go into the cell. So if we don't have that key, we don't have that insulin, that glucose that you ate rice, it's knocking on that door, but it's not opening. So it will stay high in your blood. So yes, we need to make sure that we take good control. But the only treatment for type 1 diabetes as of today is insulin, right? For type 2 is different. For type 2, we don't start with giving insulin. Type 2 is, again, eat healthy, make sure that we monitor what you're eating, decrease your sugar or carbohydrate intake, increase your vegetable, increase physical activity for type 2. Actually, and for type 1 as well, for everyone, right? Kids and adolescents should be doing approximately 60 minutes per day of physical activity. So I always remind them that you need to be physically active. For type 2, the management, we do have like an oral pill, which is called the metformin. So we start with metformin in some of the cases, and in others, we may need insulin as well. So in type 2 diabetes, patients could be on insulin or not, versus in type 1 diabetes, that definitely is insulin. And again, in pediatric, we just use insulin, but in adult, there's other medications that we could give.
Yeah, we don't need to go into those. I was mostly referring to, like in the type 2 diabetic adults, sometimes we give a medication just to protect the kidneys, even if they don't have high blood pressure, even though it treats blood pressure. And I just didn't know when that comes into factor for type 1, if at all.
You know what? Very interesting. No, not at all. Okay. We're not there yet within pediatric, but I do know, now we're changing, we're trying to prevent the complications of diabetes by addressing in adult population, but not in pediatric. As of now, we don't do that. We just give insulin.
And have you experienced any cost of insulin problems in your practice?
So yes, I have seen it in the different states I have been is a little bit different, but definitely the problem with the cost of the insulin brings some risk for patients. For example, I do remember some years back, patients were kind of diluting the insulin, right? Because it was so expensive.
Wow.
And yes, they will have these poor control diabetes and they will say that I just can't afford it. And they were just trying to save it, or they will give it just once a day when they were supposed to give it 3 times a day to cover meals. So yeah, this is something that impacts patients and patient care.
I did read something that it is supposed to get better, the cost of insulin. And I think you can get it. I would assume that most, at least in the US, that they're going to be able to get insurance that's going to cover insulin as a type 1 diabetic. So I'm not that surprised if they were able to get it. However, if they weren't, I know there is like cheaper formularies at Walmart that had some insulin that's more cost effective. But I think it's supposed to get better anyway. And like I said, I don't know if it's affecting more of type 1 or just only type 2 patients that are needing it, but definitely a factor.
Yeah, definitely. And it's getting better. there's different pharmaceutical, not to mention the name, but there's different pharmaceutical recently that have announced that they are dropping the cost of insulin to make it more accessible. And this including Puerto Rico as well. So there's several of those. And like I mentioned before, even though there's new technology, for example, the insulin pump or the pens, even with the cheapest, which is the vial, right? The crystal vial with the syringe, that's the cheapest one, right? You can still get control of diabetes. I always tell my patients, not because you cannot get the newest in the market, if you do what you need to be doing, your diabetes could be controlled. So let's don't blame it just on that.
Is there anything else we missed that we should touch upon?
I think for diabetes, again, my main message is to make sure the community know how to recognize the signs or symptoms of diabetes, and doesn't mean to panic like, oh my God, now my daughter, my son is urinating at all, but it should trigger a red flag, say, let me just get him checked or get her checked. Because again, we see usually already when they are in the ER very sick. And when we ask the parent on the history, oh yeah, they were month urinating a lot, or they were month in which they were losing weight and I didn't know why. So education is very important, knowing the signs or symptoms for diabetes so we can prevent complications.
I think we should touch upon glucagon real fast. Do you still provide all of your patients with a glucagon pen?
Definitely. So now, yes. So glucagon, it's a hormone that is normally produced by our body that do the opposite of the insulin. So it will help us bring the glucose or the sugar up. So every patient that is on insulin for treatment of diabetes should always carry with them the glucagon emergency medication. It's like a patient who has allergies that has the EpiPen with them. So for diabetic, it's the glucagon. In the past, it was called glucagon emergency kit. That is not produced anymore. It was discontinued in December 2022. However, we have other options of pens, and another one that is intranasal glucagon, which is even like easiest. So yes, for patients who have low blood sugar, usually we tell them, if your sugar is below 70 and you're okay and stable, go and get some sugar. So for example, you can get like glucose tablet, maybe 4 ounces of juice, something to bring it up, and recheck in 15 minutes. If the sugar is above 70, you're fine. But in those patients in which they have hypoglycemia, which is the term for low blood sugar, is less than 70, but they're unconscious or they're throwing up so much that they can bring up the sugar with juice, for example, that's when we go into the glucagon emergency medication. And that one is a spray that we in one of the nostril, and then we check in 15 minutes. Or we can use the new injections as well. Important message for everyone. If we use glucagon, if we're already at the situation in which we needed to use it, we need always to call 911, because there's a rebound, meaning like it will increase your sugar right away, right, to save life. But at the same time, maybe 30 minutes or so after, it could have a low blood sugar and it could be more severe. So if we need to use it, always call 911 to make sure we're stable. But it's a life-saving medication every diabetic patient should have.
I also think if you have a good friend with type 1 diabetes growing up, it's important to teach their friend how to do it, and the friend's mom and everything like that. We do the similar, teaching with the EpiPen, like you mentioned.
That's awesome. That's very important. And in that case, imagine if they're passed out, of course, they cannot give it themselves, or they're so weak, they're vomiting. So everyone at home should know it. And I usually tell them, you're going to have at least once at home, the glucagon. Everyone in the family should know in which cabinet it is. And also you should tell your friends, or you should in school have one, because you may not able to give it yourself. Someone else should know.
Absolutely. Yeah. Anything else that we missed, you think?
I think so far it's okay. There's a lot that we can go into, but these are the basics. So I think the important message, I think we discussed that.
And where can everybody find you?
Well, they can go to my website. My website is www.eliteendocrinemd.com, or in Instagram, I do have my professional Instagram, which is Elite Endocrine MD _Dr. Perez.
Perfect. And we'll put all that information in the show notes. And thank you so much for coming on the podcast today. I hope everybody got a lot out of this. It's super important to be aware of type 1 diabetes, and obviously the differences between type 2 and how you can actually save someone's life if they have type 1 as well. So thanks everybody for joining us, and tune in next week. And if you need a doctor in Clearwater or Palm Harbor, Florida, look us up at www.cfma.health, because we're in the business of health. Take care.
Thank you so much for having me.